Well, this is like you're not supposed to punish the people at church. You know, you're here on time. We're not going to wait for anybody else. We're going to give the very best stuff right in the beginning. This is about telemetry. Maybe the Australians don't care about telemetry. Do you have telemetry in Australia where they have like these little machines that, you know, do that kind of thing? Telemetry at our hospital, and I think at many hospitals, is really a problem. I think it is the single department that results in patients being held the most in the emergency department. Because you have somebody needs to go to the ward with a case of pneumonia, usually no problem, there's usually a ward bed. Yeah. But telemetry is a problem because there's less telemetry beds than the rest. And they can't get a patient into telemetry. And you can't get a patient into the ICU because nobody has the intestinal fortitude to move patients who ought to be out of there, step down to telemetry. So it's a problem. I think if we could fix telemetry, we could probably fix the whole situation to a substantial degree, obviously not all of it. So the first question, what are the admissions and discharge criteria for patients on the telemetry unit? Do you have admission and discharge criteria where you are for telemetry or the ICU? And the answer is, doctors don't know what those criteria are if they exist. We don't know about no stinking criteria to get in and out. Yet, there are people who have made criteria about what qualifies to get you in and what qualifies to get you out of telemetry. Medicare uses these kind of things. Insurance company uses them because doctors generally think their patients are going to get a little better care if they go on telemetry. Maybe the nursing ratio is a little bit better on telemetry. They'll get a little bit better look on telemetry. So there's this company that's it's listed in there it's called Interqual, which is the division of McKesson, which is this big I don't know, medical something or other company. McKesson has come up with the Interqual criteria. The Interqual criteria, anybody heard of the Interqual? They mention it periodically. Anybody ever hear of the Interqual criteria? These are supposedly evidence-based, validated criteria which would qualify somebody for getting into ICU or into observation or into telemetry units. And also has criteria for leaving those units as well. The problem is that these Interqual criteria are not known by any of the doctors, are known by the UR nurses at the hospital, are known by the insurance companies, and they result in this conflict of patients going to these units who may or may not need them. As an example, have you ever seen an article in the literature that talks about we're not admitting enough patients to telemetry? There aren't any. There aren't any. It doesn't exist. You won't find one. All of the articles on this topic talk about people who are being admitted to telemetry but who don't get any value out of it. So we're going to focus on that in a bit, but before that, I'd like to just go about this business about conflict between the doctors and the hospital. So we're admitting every Tom, Dick, and Harry to telemetry. They don't meet any criteria. We're not aware of the criteria, even though they're there. The criteria are in a book. Interqual has a book that lists the criteria, very black and white, very auditable criteria. The potassium is this. It's very black and white. Those books are highly guarded, very expensive, and you're not allowed to distribute the information any other way but by those books. Hospitals have to subscribe to the program, and the bottom line is they might have one in the nursing floors, but the doctors don't go to it and look up the book. So there is this ongoing conflict between the doctors and the UR nurses. And the UR nurses are like, they're like the people who work in the airline in the lost baggage department. What would you have to do to screw up so bad that you have to work in the lost baggage department at the airline? You know, you have not one happy person coming up to your counter to talk to you. Well, that's the UR nurses, the utilization nurses at the hospital. Nobody wants to talk to the utilization nurses because it is perceived that the UR nurses are about getting these people out of the hospital, and the doctors, they make money for every visit that they go to see the patient. So, and they don't want to send the patients out prematurely, and so there's this conflict. DRG payments for the hospital by diagnosis, and per diem payments by the doctor. So there's this fundamental conflict. I don't know if you saw it yet, but there's a couple of hospitals now where they're trying DRGs for doctors on some diagnoses, not across the whole hospital, just on some diagnoses. Obviously, if there were DRGs for doctors and DRGs for hospitals, then we'd be more in sync. And so we talk about what's the average length of stay. Well, our hospital's average length of stay is 6.5 days. It should be 5 days kind of thing. And we always hear every month at the committee meetings, you know, the adjusted length of stay is not good, not good, not good. So that's a problem that it would be interesting for you to go back to your hospital and say, listen, can I see the interqual book? And can I see the criteria that we're using for supposedly admission to these places? You'll see it, you'll be surprised. But that's what they're using of virtually every hospital. And in fact, at the back of this chapter, there's an essay that I wrote for Emergency Medical Abstracts that talks about this topic and goes into some more specifics about it. So what have the studies shown regarding the utility of telemetry? Well, here's the first one. So you have somebody, number one, is a person who is going to be admitted for chest pain. But you think they're stable enough to go over for a chest x-ray on telemetry in the emergency department. How many of them get any benefit from going over on telemetry to their chest x-ray? They're going to be admitted to the hospital. So this is a study of 3,051 people, and there was no life-threatening arrhythmias. Have any of you abandoned, like, going up to taking people up to telemetry with a nurse or anything like that, or on monitors? Or, have you abandoned that? Well, the next paper will help you abandon that. A lot of this is risk tolerance. What are you willing to tolerate in terms of risk? Are you willing to tolerate 1 out of 3,051 patients having a life-threatening arrhythmia going over for an x-ray? 1 out of 30,000? Number two is 322 low-risk chest pain patients. No pain at the time of the admission. Normal or non-diagnostic EKGs and normal troponin. And that's the mantra of low-risk chest pain. No pain now, troponin okay, EKG is normal or non-specific. So these people were going up to the floor. How many of them had any adverse event during their transport to the floor where they were going to be monitored? None of them, none out of 322. Well, maybe that's not enough patients. Maybe you need 3,000 patients to say that was safe. But have you had any problem with anybody going to telemetry, arresting in the elevator kind of thing? It doesn't happen. It doesn't happen. But will we ever go back and say, well, we don't need it. You know, just get them up here, get them up, kind of thing? No, we never sunset on anything. We just keep on adding new stuff and new stuff and new stuff and medication reconciliation, and add this on top of that, and learning preferences and more. Your nurses doing triage, do they do a thing called where they ask them about, they make a nutritional assessment? That's one of the things that Joint Commission wants, is a nutritional assessment. You see that box, a nutritional assessment? Learning preferences. Yeah, I'm a kind of visual learner. Can you draw me some pictures, please, kind of thing, you know? I've never heard of one of our nurses in the process of doing their nutritional assessment saying, you're too fat. You know, they don't say that. They just check the box, check, 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 check. But, you know, we're the victims of everybody. So, well, let them do it in the ER kind of thing. So there was no problem here. 5% of the patients, this is a good number, 5% of low-risk patients, normal EKG or non-specific, normal troponin, and no chest pain now, 5% of them had a myocardial infarction. And that number is a number that comes up over and over, number 3, 4, 5, you know, in that neighborhood, 5, 6% kind of thing is the true rule-in rate in that what appears to be a fairly benign subset. So this says if you take 322 patients, and 95% of which had no coronary problem, they all do fine when you transport them to telemetry, because they didn't need to go to the telemetry in the first place because they didn't have the problem of a myocardial infarction, which we were looking for in the first place. The vast majority of the people who are going to telemetry from the emergency department are these chest pain, soft chest pain kind of cases. So the question here is, do low-risk chest pain patients need to be admitted to a monitored unit at all? Clearly a radical question. And the question is, will the evidence, which is fairly compelling, change anybody's practice? So number 3, the title says it all. Is it necessary to admit low-risk? So this is a review of 10 studies, 16,445 of these low-risk patients, and less than 1% had significant events, less than 1%. Well, is that good enough? Are we willing to go for less than 1%? I'll show you some numbers that are actually, you know, 0.5% or less. So it's like 1 in 200, 1 in 400. I'll show you a lot of these papers are 1 in 500 patients will have something happen in association with being on telemetry. So this guy concluded, who wrote this paper, Dr. Chen, although there is not a zero-risk strategy, because a few patients may develop a major adverse event, it would still be considered within the standard of care to admit those low-risk chest pain patients to an unmonitored unit. Standard of care is what doctors do. This person says that it would be within the standard of care to do this, but the fact of the matter is I doubt that the standard of care is to do this. I think probably most people would admit these low-risk chest pain patients to a telemetry unit. So you cannot state what the standard of care is like this doctor is doing. The standard of care is what doctors do. And doctors admit patients to telemetry units who have low-risk chest pain patients. 16,000 cases. Is that atypical? Well, one of the studies, the largest of those 10 studies, is more specifically picked up in number 4. 8,900 patients admitted to telemetry over a 5-year period. The criteria for admission was the physician's judgment. Cardiac arrest, how many cardiac arrests were there? 1 in 500 patients, 1 in 500. Well, maybe 1 in 500 would be good if we caught every one of them as a result of telemetry. But if you look at the abstract, the arrests were recognized as a result of monitoring in only 9 of the 20 patients. The other 20 they arrested, nobody noticed it on the monitor. Mr. Smith. Then they looked in a subset of those patients, a subset of 4,300 with an admission diagnosis of chest pain of undetermined etiology, angina, unstable angina, or rule NMI. One of those 4,300 developed a fatal cardiac arrest. That's 0.02%, 1 out of 4,500. So, and lastly, number 5, lack of utility for telemetry. 1,000 patients, that's number 5, low-risk chest pain patients, meeting the same definition as before. Goldman risk score. You hear about this Goldman risk score in terms of ranking people in terms of the risk of having a problem, a cardiac-related problem. And we'll talk about what are the elements of that in a second, but Goldman risk score below 8%, which is low risk, and initially negative cardiac markers, which is what you needed to have. So they took this low-risk group. One of the things that comes up over and over and over is, by far the majority of patients who you admit to the telemetry units are low-risk patients. In this study, 59% of all ED chest pain patients admitted to telemetry were Goldman low risk. 58%. And I'll show you other papers, 60%, 50%, 55%. It is not the minority by any stretch of the imagination. It is generally 50%, a little higher. So the final diagnosis in the Goldman low-risk criteria patients was an myocardial infarction in 1.5%, 1.5, unstable angina in 12%. None developed sustained V-tach or fibrillation. So it's none out of 1,029 low-risk Goldman criteria patients. Pretty small number. 0.4% of 261 patients with non-traumatic chest pain developed sustained V-tach during this was like one patient, and he had had a surgery for an aortic dissection. The rest, no problem. Number 7, same theme. It's always the same. Only 4 events occurred among patients with atypical chest pain in this study, normal EKGs and normal lab values. And so that the next papers talk about if we were able to formally risk stratify these people using like the Goldman criteria or something else, could we just say, okay, all low risk or very low risk patients, they don't need to be monitored, despite the fact that we're admitting them all to telemetry. They represent 60% of all of the chest pain patients we see, or thereabouts. So that's addressed in papers 8 through 12. There's 5 papers here. Number 8 used the modified Goldman decision rule to stratify patients. Looked at their cardiac complications within the first 72 hours. The Goldman rule is a EKG with no elevation of ST greater than 1 millimeter, no pathologic Q waves, no systolic blood pressure above 100, no rails at the bases, known no known prior angina. Using the rule, a third of the patients were admitted to an unmonitored ward bed or ED observation. And before the rule, 21% of the patients were admitted to an unmonitored bed. It was amazing that they had anybody admitted to an unmonitored bed, considering what the standards are in the United States. Every chest pain that is thought to be, could be, maybe, possibly, is going to go to a telemetry bed. They went from 21% of the people not going to a telemetry bed by using the criteria to 36% not going to a telemetry bed. And what was the problems in terms of risk? 0.8% of the very low risk patients, which is 4 out of 481, had a cardiac complication, 4 out of 481. So the answer is not 0, but it's darn close to 0. In this study, very low risk patients represented 48% of the 1,008 patients in the study. So the other paper we mentioned was in the 50s. This is 48%. I'll show you some that are in the 60s. Number 9 also used the Goldman risk stratification criteria, and the rate of cardiac complications in their very low risk category was 0.2%. That was 1 in 500 patients. Very low risk patients in this study, number 9, represented 52% of 1,033 patients in the study. So paper after paper after paper. So the vast majority of the patients we admit are low risk criteria, and in those patients who are very low risk criteria, pardon me, the risk of anything going wrong is really, 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 really small. Especially if you put that in the context of, well, where you want to hold them. You want to hold them down in your ER indefinitely because you don't have a telemetry bed for them, and are they going to get any better care down there? 10 is a similar paper. In this study, in number 10, 52% of the patients were very low risk by Goldman criteria. Very low risk patients, how many complications in this number 10? 0. 0. 11 is the original Goldman paper. It was in New England Journal or something like that, or JAMA or something, number 11. So he did this prospective study to develop a risk stratification score, and then he validated it in another group of people to see whether what they did on the derivation set proved to be true on the validation set. In his study, 0.1% in the derivation set had a major cardiac complication at 12 hours. 0.1% last order is 1 in 1,000 people. In the validation set, it was 0.2%, 1 out of 500. Number still very, very, very small. But are we willing to accept 1 in 500 in the United States of America? And then there's the paper that gives into you how many had complications at 12 hours and 24 hours and 72 hours. And the numbers vary between 0.2 and 0.3 and 0.1. So of this study involving almost 9,000 people in the derivation set, 69% of them were very low risk category. And in the validation set of 4,600 patients, 55% were considered to be very low risk, over and over and over. But we treat the very low risk just the same as we treat the high risk. Everybody goes to telemetry, unless you can prove that you need to go someplace worse, like the ICU. And then lastly is number 12, which uses a computer formula that is built into the EKG machine. So you put into the EKG machine the patient's age, and the EKG machine cranks out this EKG, applies this formula to the thing, and comes out with a risk stratification. This never took off. Does anybody have an EKG machine that has this thing in it? They never sold this thing. But this certainly, you would think that if physicians were willing to make some modifications of their behavior, this number 12 said it reduced the CCU and telemetry admissions substantially. In fact, when they looked at the patients discharged from the emergency department, chest pain patients went from 10% to 21%. They could look at all the money they saved by giving them the confidence to say, you don't need to come in the hospital. It doubled the number of patients who were sent home. So that's focusing on the patients who are ACS, could be maybe heart patients, arrhythmia cases. The literature is compelling. The only question is, are you willing to settle for something like 1 in 500 having a problem?
How do you reconcile this with all those studies we've seen through the years about 2%, 4% of the MIs get sent home?
That's true. That is the number, 2%. We never have been able to get better than that unless we admit everybody who comes to the hospital, no matter what you're there for. Sprained ankle could be a silent MI, you know?
It's like the ones we send home do worse than the ones.
I don't know that necessarily is true. I think the data on that is kind of conflicting. Some people say that the 2% who go home have a high risk of dying. Others say that's not necessarily the case. We hear about the 2% who go home who come back and have a bad outcome or are found dead. But we don't know about the 2% who go home who do just fine. They don't report on those. The next set of these papers is about telemetry for other cases other than just chest pain patients. And my favorite paper here is number 13. This is from Hoag Hospital, which is in Newport Beach, California. It's where the beautiful people live in Orange County kind of thing, where all those wives go who are kind of got nothing to do. Hoag Hospital, and it's staffed by a group of docs from one of the guys is from my class at USC, got out in 1975. They retrospectively looked at 236 of their telemetry admissions. The American College of Cardiology has come out with some guidelines for admission to the telemetry unit. As you might consider, they're related to arrhythmias and heart-related problems. And then they got the doctors at the hospital to embrace these American College of Cardiology guidelines. Plus, they did some local tweaking. So they did this local consensus. They added some, deleted some, those kinds of things. And so they had something where you would have thought the medical staff would say, okay, we got it. We're going to accept these guidelines, we're going to tweak them ourselves, and we're going to follow them. They looked at these 236 admissions. 54% of the admissions were considered justified using those criteria. 46% therefore were not justified to the telemetry unit at Hoag Hospital. 95% of the dysrhythmias occurred in patients who were justified admissions. That left 5% of the cases had arrhythmias who were not justified to be there. The 9 events, and those 9 events that occurred in unjustified admissions were relatively minor, none required specific interventions. The only choices that you have in the hospital with regard to telemetry is to try to control entry and exit if you're trying to get patients out of the ER, is to control entry and exit or make every bed in the hospital a telemetry bed. And some hospitals are doing that. Some hospitals think it's really cool. We're going to have every bed telemetry. That way you can waste a lot more money than we're wasting now by making every bed. But we cannot even justify the telemetry patients being monitored. Now let's make every bed in the hospital. It's very cool. Private room and every bed will be monitored. So any of your hospitals doing that? Every bed monitored kind of thing here. We need more and more and more telemetry. The fact of the matter is that we need less and less and less telemetry, but that's never going to happen. But it's good at least not to have any delusion to think that this really, really matters. 14 and 15 are by the same author from Henry Ford Hospital. 14 is looked at 467 telemetry patients, mostly chest pain cases. 2/3 of them had telemetry definitely indicated by the American College of Cardiology criteria. 1/3 of them were probably indicated, and 2% of them were not indicated. Only 2% were not indicated. That sounds a little strange. Telemetry was a factor, and only 5 cases transferred out from telemetry to the ICU out of 30%, 38%. 38 of the cases that went to ICU, only 5, which is hardly any, were due to something found on telemetry. His second paper is number 15, 2,240 cases. Telemetry was considered helpful by the doctors in 1 out of 8 patients, changed care in 1 out of 14, but only 0.8%, less than 1 out of 100, of ICU transfers were solely determined as a result of telemetry findings. Actually, it's 1 out of 120 who got transferred to the ICU was because of telemetry findings. In those people who were thought not to require any admission as a result of criteria, hardly any of them, less than 1% of the problem. There you go. Only 4 of the 20 deaths occurring in the telemetry unit occurred during monitoring. It's the same as the other paper. They had deaths, but a lot of them, they weren't even, it wasn't as the result of telemetry. What did they die from? 2 of them died from aspiration, and 2 of them died from some kind of sudden ischemic process. 4 out of 20 deaths occurring in the telemetry unit occurred during monitoring. How can you be on telemetry and not be monitored and then die in the process? That doesn't look good. Telemetry in pre-hospital care is a waste of time. Sending the arrhythmia from the EKG to the hospital, that's 16, 17, and 18. Basically, it's either too fast or too slow. You either shock them or you give them atropine. That's it, done, thank you. In the field. And I wanted to talk to you briefly about the paper at the end there, that little summary, because it talks about a paper by Dr. Chen and Dr. Hollander. They did a paper which is summarized in the second half of that essay that I wrote about people who need telemetry, people who may benefit from telemetry, and people who get no benefit from telemetry. And what they did is they looked at, I think it had like 60-some references, looking at what is the evidence to put somebody in telemetry. And using that, they came up with these 3 categories. So I wanted to focus on the people who don't need telemetry. They say blood transfusions don't need telemetry. I don't know why a blood transfusion would routinely go there, but they said if you got to give them a couple units and the person's otherwise stable, even if they have an acute bleed, they don't need to go to telemetry. They also say, look, this is almost a quote out of that thing, low-risk chest pain patients, there's a 1% risk of life-threatening arrhythmias and a 0% risk of sudden death, is what they said. That's from their analysis of the literature, which goes hand in hand in what we just talked about. So they said low-risk chest pain patients, which are troponin negative, no more chest pain, no arrhythmias in the, during their ER period, no more recurrence of chest pain, and an EKG that is normal or nonspecific. That is considered to be a low-risk chest pain case. Look at number 3, COPD exacerbations. These people are getting inhaled adrenergics. They're old. They got everything wrong with their lungs, got 3 alveoli to their name. And they concluded that COPD exacerbations, unless there is perceived to be a cardiac etiology to their dyspnea, it should not be put on telemetry. Going right to the floor. Now, you may disagree with that, but if their pitch was, we looked at the literature, and we couldn't defend it based on what the literature says. And then lastly, like stable PE patients. You have patients got PE, you know, you would think, oh, they don't go to the floor. Who are you going to put, if you don't put a PE patient on the telemetry, who are you going to put there? But there are these PE patients who go home. You know, do you have any kind of places where you send PE patients home for their heparin shots and that kind of stuff? Yes, any of you do that? Kaiser does that kind of thing. They came up with, they were among the leaders in sending people home. And we had a great paper. We have a great paper that said people who have DVT, they did lung scans on them. They were asymptomatic except for DVT. They did lung scans on asymptomatic patients with DVT. 50% of them had high risk for PEs, 50%. They had already embolized. They had already embolized. So that those people who went home with their DVT treatment, a good number of them, they were also being simultaneously treated for their PE. It was just never diagnosed because they didn't have symptoms because it was small. So these guys say stable PE patients could go home. Who are they? They're low-risk patients. Same patients who go home certainly would not require to be admitted to a telemetry unit. They're like under 70, no prior history of cancer, CHF, COPD. Heart rate is kind of not high, too high. Blood pressure is not too low. It's listed in there. These are the criteria that some people are using to send people home with PEs. Certainly would not require monitoring if you were to admit them. And they say the last group of people is the people who they say monitoring may be beneficial. Syncope admits, well, yeah, I think it's probably true. GI bleeds after endoscopy. There's a whole list of reasons why after endoscopy people are at risk for arrhythmias. They're talking about the drugs that they got, the vasopressin that they got. They're talking about the sodium moreuate that's sealed up their blood vessels, and the fact that endoscopy has a variety of reasons why after it is over, they're at increased risk of arrhythmias, which I wasn't aware of. They talk about atrial fibrillation and atrial tachycardia in people who are having active treatment. They get their rate slower or convert their rate. Electrolyte abnormalities, the big 3 being potassium, magnesium, and calcium, but we only have 2 of those because we don't measure the third, the magnesium. No specific thresholds have been set if the EKGs are normal. We had a, this is the honest to goodness truth, and in fact, it even says it in that book there, reportable case. 2 weeks ago, we had a potassium of 9. Obviously a mistake, send it to the lab, potassium comes back 9. EKG, perfectly normal. So what the heck is that about kind of thing? Well, it does mention something like that Normally, by the time your K is 6.5, your EKG is starting to look a little weird. But these are case reports, which means that by definition, if it's a case report, it's going to be very, very unusual. And they talk about patients who may get some benefit are those who have subacute CHF. Obviously, the acute CHFers, high risk for arrhythmias, they should be admitted. So the thrust here is maybe some of this information could be used to try to deal with the fact that the hospital has got their monitor beds clogged up, because most people there have not been put in there with any criteria. And when they're clogged up, patients from the ICU can't be brought down, patients from are being held in the emergency department. And so if you were going to attack one spot in the hospital, it would be telemetry. By far, the literature says the most patients who go there get no benefit. No benefit. So, and the other implications are, if you have people there who get no benefit, but there are people down in the ER or people in the ICU who could certainly move there, so you've got the bed being clogged up by somebody who's not getting benefit while it is needed for this patient who's down in the ER. How many of you in your ERs have monitor watchers now? Monitor watchers? Let's see the hands. Don't raise them all at once now.
Does this exclude other patients watching each other?
No, these are designated monitor watchers. So one hospital.
Are you a secretary that doesn't have to go through a training to be monitored?
So they're doing both. So one hospital represented in this room has monitor watchers in the ER. How does that work? Don't you have to have a monitor watcher on the floor where they go to telemetry? Don't they have these people just sitting there watching these things? How do you get away without having anybody assigned to watch that kind of thing? One of the ways that you might increase your staffing is 2 standards of care. Telemetry has monitor watchers. You got 12, 15, 20, 50 beds. None of them are being watched by any soul. It's just random chance. Oh, look at that one. We're going real fast there, kind of thing, as people walk by. So you basically talk to your administration at 2 standards of care here. In the ER, we need monitor watchers. Just like you have them on the floor, we need them down here. We got 20 beds monitored. We got 15 beds monitored. We need monitor watchers. Of course, you don't need monitor watchers, but it'll help you get more staff. And that's exactly what we did. About 2 months ago, we got monitor watchers in our emergency department because that was the way it was justified to have another soul down there. They went to some arrhythmia class, you know, too fast, too slow. That's it, fine. I don't need to know anything else. Too fast, too slow. And now we have this person who really is putting in orders for the doctors and doing other kinds of things, but they're there under the guise of being a monitor watcher, because you can have 2 standards of care, which every hospital in here has 2 standards of care, because they got monitor watchers upstairs. And you may have more monitor beds than the monitored unit has. So something to consider, something that might be used as a tool to facilitate you getting a little bit more help in the department. All right, that's enough of that. Any questions, comments, disagreements?